Hello everyone. So now we continue with our discussion of the infectious disease system. So this case they give you 34-year-old man came in with 20 mm erythema and 2 mm in duration after TB skin test, and they tell you what to do. Okay, and this patient nothing. Why? Because you only care about induration, you don't care about erythema. Okay, this is the teaching point here. So if the induration, if somebody is healthy, you need induration of 15 millimeter. If child or leukemia or someone working labs or high risk, like someone nursing homes, hospitals, homeless, someone work in high risk setting, doctors like for us, the same thing, injection drug user, immigrant from TB endemic area, it's more than 10. Okay, if someone has HIV, close contact with TB, some fibrotic changes on X-ray, or have some transplant, then this is the cutoff. Lower it to 5. Okay, that's kind of the things that we need to worry about. Okay, now this patient, another case, you see 33-year-old came in with fever, fatigue, headache, okay, for 5 days, and then you on exam there is maculopapular rash to the trunk without central clearing, and then there is a platelet is low, like 90,000. There's leukopenia, white BC is like 3,000 or okay. So what caused that? What's the diagnosis? What causes this issue? Okay. Anytime you see maculopapular rash, fever, and thrombocytopenia, this you think of tick bite, like some kind of tick infection. So this is called Ehrlichia. Ehrlichia chafensis. If you want to know other information about Ehrlichia, this Ehrlichia travel on the same tick that carries Lyme, Ixodes tick. Okay, this is Ehrlichia. It's called Anaplasma phagocytophilium. Okay, this is the bacteria that causes that. Usually northeast and midwest in the United States, midwestern. And there's another tick that's caused. It's called Ehrlichia chafensis. So there's Anaplasma and Ehrlichia. Ehrlichia it's travel on the Lone Star tick. This is in the south and southeast United States. So in the Midwest, it's Anaplasma, Ixodes, Lyme. In the southeast and south central, this is the Ehrlichia chafensis. Usually present with fever, myalgia, headache, vomiting, lymphadenopathy, altered metastasis, rash, maculopapular petechial, without central clearing in 30% of patients. So this is like diffuse symptoms. Okay, other labs finding leukopenia, thrombocytopenia. So when you see combination of these systemic symptoms with thrombocytopenia, elevated transaminase, okay, and you see intraleukocytic morula, so you can see that on peripheral smear, PCR as well. This you manage with doxycycline. Okay, you manage with doxycycline to prevent complications like seizure, renal, respiratory failure. You know, these kind of things that you want to be aware of. Okay, now you have someone. Okay, now this case, so they ask a lot about HIV. HIV is pretty high yield. So this is what you would do. Okay, somebody 33 has HIV, 33-year-old man has HIV 2 months ago, okay? And then you started him on antiretroviral therapy, right? So you started antiretroviral therapy. After you start antiretroviral therapy, what would you do? What is the best thing after that? Okay? So after antiretroviral therapy, the patient developed cough, dense consolidation, and CD4 improved. And they tell you, okay, what's best next step? Do you stop? What do you do? Do you stop antiviral? You continue? What do you do? So the answer would be continue antiretroviral therapy and send sputum studies to see what kind of bacteria is causing this trouble, right? So because there are several opportunistic infections that are associated with immune reconstitution syndrome. That's what it's called, immune reconstitution syndrome. The body is gathering its forces. The ones that causes issues: Mycobacterium species, cryptocytomegalovirus, hepatitis B and C, herpes simplex virus, HHV8 as well, John Cunningham polyomavirus, and pneumocystis as well. Okay, so these things can cause can cause problems. Okay. Now we have another case. You have a 26-year-old came in with ear pain and decreased hearing. Okay, so on exam you see cloudy, red bulging tympanic membrane, and you place the tuning fork lateralizes to the right. Okay, so what is best next step? This one clearly otitis media. So what do? You start amoxiclav. Okay. So if someone just taking amoxicillin, like may not work amoxicillin alone, you should need amoxiclav. So amoxicillin is the first line antibiotic. If that doesn't work, then you do amoxiclav. If otitis media don't resolve in 48 to 72 hours. Okay. All right. So now we have another case. 25-year-old woman came in with 7 millimeter induration after TB skin test. Okay, so now this is more than 5 millimeter. Okay, so what would you do now? This depends on her risk factors. Okay, if she has been living, so this is, they tell you, okay, living with TB patient for 3 months. 3 months ago she was living with TB. So there is recent exposure to somebody with TB. So we said if there's close contact with TB, you treat them same as if they're HIV or if they're transplant or if there's X-ray findings, because these are patient high risk. So what is best next step? Okay, best next step, you do INH isoniazid plus rifapentin weekly for 3 months. This is the easiest thing, but just 12 doses and that's it, you're done, you know. This is the best in my opinion. I like less dose, less drugs. Okay, for 3 months and you're done. Other options, you can do rifampin daily for 4 months, or you can do rifampin plus isoniazid daily for 3 months. Okay, but if you want to substitute rifampin with rifapentin, like in this case, you should do it weekly and you're good to go for 12 doses and that's it. Or you can do isoniazid monotherapy 6 to 9 months. Okay, and in this case you depend on the cost and all of that. But for doctors, like if you're just a doctor or nurse, you treat them same as if they're the IV drug users, somebody with endemic area, somebody immunosuppressed like diabetic, leukemia, end-stage renal disease. You treat them the same way. 10, which is 10 millimeter induration. If they're completely healthy, they're not close to the hospital, just like 15 millimeter. Alright, now we got another case. If you see 29-year-old came in with body aches, okay, and then maculopapular rash on the trunk with patchy area of hair loss, plus there's rubbery palpable lymph nodes in the anterior and posterior cervical areas, okay, and the penis is uncircumcised. There's elevated liver enzymes, elevated LFT, alkaline phosphatase, you know. What's your diagnosis in this case? This most likely is called secondary syphilis, okay. Because this brings us to the discussion, what is secondary syphilis? Usually causes fever, malaise, anorexia, diffuse lymphadenopathy. Like a lot of things can cause that, right? Maculopapular rash can cause, a lot of things can cause that too, okay? But the specific here, it's palms and soles affect that. Can cause condyloma, latum, which is painless wart-like lesion. You can see that. Moth-eaten alopecia, that's a specific. Patchy area of hair loss, this is specific, you know. Diffuse organ involvement, hepatitis, uveitis, meningitis, you can cause that, secondary syphilis, okay? So that's kind of the difference between like syphilis and just like regular infection, you know. So if you have these systemic symptoms, maculopapular rash with thrombocytopenia, this may be tick bite, like Ehrlichia. But if you have like patchy area of hair loss with rubbery palpable lymph node, palm and soles rash, this may be syphilis, most likely. It's all about the most likely. Okay, another interesting case. I like infectious disease, kind of interesting. You see 36-year-old came in with nodules on hands and forearm. Okay. He's landscaper. Okay. So landscaper, there is biopsy shows mixed pyogenic and granulomatous inflammation. And so what's the diagnosis here? Diagnosis is sporotrichosis. Sporotrichosis can cause these things like landscaper and nodules, you know. Alright, now the second case that you would see, somebody who has HIV came in with perianal pain and ulcer. What's best next step? What is the diagnosis, I mean? So we know herpes causes ulcer of the mouth, ulcer of the penis, if it touches the anus, can cause ulcer, especially in homosexual, can cause that, you know. So HSV infection. So it's ulcerate anything it touches, okay? So that brings us to the discussion. There is painful genital ulcers and there is painless genital ulcers. So the painful genital ulcers, there are two causes. Herpes simplex, the way they describe it, pustules, vesicles, small ulcers, tender lymphadenopathy, systemic symptoms can be common. And there's herpes simplex virus is the most painful virus ever, okay? Very painful. And their hemophilus do cry, makes you cry, so it's painful, chancroid. But this one's be larger also. There's well demarcated border, there's severe lymphadenopathy, may separate lymphadenopathy. So this is the painful. How about the painless, the one that are mild? Usually the one that syphilis, chlamydia, you know. So syphilis, usually the way prescribed, usually single ulcer. It's not multiple like herpes. Single and indurated border and hard, non-purulent base. Okay. Chlamydia, usually small, shallow ulcer. That's why sometimes it's missed. Initially painless, but then becomes painful later, and they could cause the fluctuant adenitis. You know, it's called buboes. Lymphogranuloma venereum. Alright, now, so you have somebody had like someone 41-year-old had Lyme disease, and then now he has fatigue, muscle aches, stiffness. They tell you, hey, what to do. What do you do? Supportive care. Okay, nothing else, honestly. Antibiotic are not indicated, and spontaneous resolution within 6 months usually. So you don't need, just wait. Sometimes just wait is better. Alright, now another case is kind of interesting. You see 60-year-old came in, difficulty walking, okay? Difficulty walking, you see early diastolic murmur. Which we talked about that, this is maybe aortic regurg, okay? Difficulty walking, and then you see some reflexes diminished, unsteady gait, decreased sensation, you know. Okay. There is wide mediastinum as well. And then they ask you, how do you don't know the diagnosis or best next step, right? And they ask, is it heavy metal poisoning, protein electrophoresis, or treponema? This one you check treponema, pallidum, enzyme immunoassay. Okay. Treponema, pallidum, immunoassay. Okay. Because this is syphilis and this is called tabes dorsalis. Okay. And that brings us like, so how do you treat this situation, right? So how do you treat that? It's called neurosyphilis. The way you treat it, penicillin every 4 hours for 10 to 14 days. Okay. And if there is congenital syphilis, you give penicillin every 8 to 12 hours for 10 days. Okay. So these are the one that you give frequent. Okay. Okay. So what if you have primary syphilis or secondary or early latent? Like you have less than 12 months of infection, you just give 1 dose of penicillin, 2.4 million units, 1 time, and that's it, you're good to go. How about the one in between, like late latent, like had a positive test like more than 12 months ago, you don't know the duration, how long they had it for. There could be gummas or cardiovascular syphilis. You give penicillin, 2.4 million units, 3 doses weekly, every week, 3 doses, 3 weeks, that's it, you're done. Okay. So that's kind of the management for syphilis. Okay. So this is to review what we talked about. We talked about treponema, pallidum. We talked about supportive care. We talked about hepatitis, HSV. We talked about sporticosis. About secondary syphilis. We talked about that as well. INH-rifampicin for TB. Amoxiclav for otitis media. Continue antiretroviral therapy, sputum studies. Ehrlichia diagnosis, and then you do nothing if there's 2 millimeter induration. And that summarizes our discussion for this.